All right. Well, thank you guys for all coming today. We have a special guest, Sam Galvagno, professor and medical director at the multi-trauma critical care unit over at Shock Trauma in Baltimore, is our very special guest today. It's truly an honor to have him here at our conference. This is our first one from outside of WashU, and hopefully a part of a bigger collaboration with Shock Trauma and other places around the country in terms of getting this trauma conference expanded a bit. But Dr. Galvagno really needs no introduction for most of us in trauma. We're very familiar with his work. Extensive history, experience in the military, published many papers, written many articles and book chapters, and today is going to talk to us about ECMO and how we can apply that in the trauma setting. And I'll just keep the intro short and let you get going if you don't mind.
Thank you so much.
The floor is yours.
Hey, thank you so much. Really appreciate being here. In fact, this conversation, if I'm not mistaken, really started with me reaching out to you because I heard how great this lecture series was, and I just wanted a link so I could listen in, because my colleague Justin Richards, who knows you folks really well, has just said nothing but great things about the program, and I've had the opportunity to hear a lot of your stuff, and just thank you for doing this. This is so important. So it's really, the honor is really mine to be here with you tonight. It's 6:30 on the East Coast, and this will be just a kind of a quick talk, and hopefully we can open it up for some discussion. I'm really going to just go through some of the basics of how we do it at Shock Trauma. It is not the right way necessarily how to do it. You'll see it's we take a very simple approach to this. I think we're fairly aggressive. I don't know if we could be more aggressive, but that's again something I'd like to hear your input on, and tell me what your thoughts are. So without anything further, let's move on here. Let me see if I can advance. There we go. So I don't really have any disclosures related to this stuff that much, really. I mean, there's some Department of Defense funding, none of which is really related to what we're talking about, though. And I will mention that I do write for the test writing committees, and I got to tell you, there are a lot of ECMO questions on our critical care boards now, and more coming. So for those of you that do critical care as well, expect more ECMO specific questions, particularly about management and some of the perioperative management. And even on the critical care, the neurocritical care test, which is the ABPN, they have a fair number of ECMO questions because there can be a lot of complications and things that need to be managed. So just stand by for that. There's a lot, this stuff is not going away. It's definitely become much more prevalent, as we'll discuss here with some of the literature. What I wanted to talk about with this evening, I thought we would just talk about some of the very brief physiologic rationale, which I think everybody on the line is familiar with. Just a quick review of that. I do want to get into the available literature, and I did spend some time looking at all the literature going all the way back at least 2 decades. That's when really this became much more prevalent in terms of public case series and so forth. And then we'll talk about at least what we do at Shock Trauma, and we can share some thoughts. And then I really want to, I thought it would be best just to give you a couple of cases of what we've had recently, including a case I just literally just came off service this morning early, technically. And there's a guy we've got in our unit who's recovering from an ECMO run. Pretty profound case that I think you'll enjoy hearing about. All right, so RAM's Shock Trauma, I need to get into too much about this, but we have a lot of admissions a year. We're busy. We have a dedicated building, blah, blah, blah. Just a busy place that does a ton of trauma and does a lot of also shock management. 130 beds, and our ORs are all dedicated to trauma, and a lot of embedded infrastructure. And I think that's important because, when we talk about doing a number of runs and high volume, you've got to have a whole unit almost that really can handle this. I know most of you, in fact, I believe at your institution, you do a lot of this work in your cardiothoracic ICU. So we actually have a dedicated ECMO unit, and we do the overflow will go to our cardiothoracic ICU. So that's how we typically run the show, and I'll share some of that stuff with you about that. But we do have a lot of admissions, close to 8,000 a year for trauma. So there's lots of opportunities and a lot of calls that we get to put people on ECMO, including trauma patients, just because they know that as our state level resource, we really are dedicated to doing that, and we've devoted the resources and energy to it. It's not cheap, but we believe it's important. So one other thing I just wanted to share with you, sorry about that, get my clicker correct here. So just want to share with you, we have a website for our unit where I work, which is our main ICU. It's basically the central ICU for the hospital. We do a fair amount of ECMO there. It's not a dedicated unit, it's an overflow ECMO unit, but if we have trauma patients, we will manage them there oftentimes. I just want to make you aware of this website, lots of infographics. You can see on the ECLS tab, that's where we have a lot of handouts there on ECMO and how we run it, a lot of like one pagers on how to do it, goals, etc., all of which we'll talk about tonight. And then just to give you an idea of our, here's the type of stuff. We have dashboards where we look at the survival. Our survival overall, now this has changed a little with COVID, not a whole lot actually. We've had about 67% survival when we look at our COVID numbers, which it's not great, but it's, and our overall survival has been running historically close to 68, 70% for all comers. We'll talk about the trauma specifically in the trauma here in this talk in a minute, but this just gives you an idea. We again have the advantage of reaching deep into DC. There's only really one other center that does this regularly in DC. And then we've even had crosstalk with our colleagues in Philly at times. And then up north, there's not much until you start to get up near Hershey and then west to Pittsburgh. So we've got a large area that we're responsible for where we get a lot of patients. So again, Blues Brothers.
6 miles to Chicago. We got a full tank of gas, half a pack of cigarettes. It's dark, and we're wearing sunglasses. Hit it.
So that's kind of our approach to ECMO. PaO2 of 45, vents maxed out, patients on multiple pressors. Hit it. We just put them on. So we try to think about it a little more than that, but oftentimes that is what it comes to. And what I would argue in this talk is, as we alluded to just before we got started with Justin, it's probably wiser to lead turn this a little bit if you can, so you're not crashing onto ECMO. If you can do it in a more controlled setting, we tend to have a lot better results when we are able to do that. That just requires having a good knowledge of kind of the vector of your patient and what direction they're going in. Look, ECMO, just a few quick thoughts on ECMO. I think, when I first started doing it, very intimidating. I know the first cases I had at shock trauma were patients I took care of in the OR as a trauma anesthesiologist. And, everybody's pretty calm and relaxed, but it just have to remember, it's just a big shunt. It is. And the cannulas are well seated. They're not going to go falling out and people bleeding to death. Those days, we figured out how to do this safely over the years. Understanding which dials are turned and why they're turned is important. Understanding the level of support your patient on is really important. And I think those are the things that have implications for us on the trauma anesthesiology end. But I just want to emphasize that really what we're talking about with VV ECMO especially, because that's the majority of our cases that we're doing, it's just a big shunt. It's a big shunt. There's an oxygenator and a circuit and some things we need to really pay attention to in addition to the normal care for our patients. But I think where people get into traps, at least I've seen this, folks that haven't had as much exposure, like when we get new attendings and they're freaking out because they see there's an ECMO patient coming down to their room for a procedure. You have to just remember, you take care of the patient with everything else. ECMO is just another layer of support that we're adding, does have some specific considerations, but if the heart's not working well, we still treat the heart, et cetera, et cetera. So I think you guys all know that. But the things that I also try to emphasize, or we try to emphasize in our program is, you can keep up with most patients, but you shouldn't be expecting necessarily normal numbers in every instance. So just as a review, 3 to 5 mils per kg is our normal VO2. And normally we have a supply that's well above that, 5 times more than needed. And the graph in the bottom is just showing that critical level where once you exceed that supply, demand exceeds the supply, and it doesn't really have to exceed it. It's just that ratio gets narrower, like 2 to 1 or less than 3 to 1 supply to consumption. You'll start to see things like the lactate rising. You'll start to see more hemodynamic instability. Certainly you will see hypoxemia at that level. And that's when you have to ask yourself the question is, am I keeping up with this patient with the ventilator? Am I going to be able to keep up with them with the ventilator? And are they a candidate for ECMO? Because ECMO can help us bridge this gap and allow the lungs to recover. But I think the important point in here is we try to emphasize is that we're fine with an SaO2 of 80%. Now, I do foot stomp the SaO2. I know that's a review for everyone on this line, but I have to remind my colleagues, SaO2 is not always exactly the same as the SpO2, high correlation, but an SaO2 off your ABG of 80% or greater is going to meet most of your oxygen demands. And that's going to give you a PaO2 in the 40 to 60 range, which isn't great. And we might want that to be higher if we have a TBI patient. But for most trauma patients, this is where we would land. And we're okay with that. And there's nothing magical that makes us think we're going to have higher numbers. We often do. But if this is your threshold, there's some things we can do to treat this, certainly. But this is actually okay in the majority of cases. And I'll explain how I'll tell you how we do it. So the DO2, you got to have a cardiac output for that, right? So how do we do that? We don't place a lot of swans in these patients. Maybe we should. Occasionally we will. Most of the time we can get by with echo. So transthoracic, or if they're really banged up, and a lot of these patients will have chest injuries, we have an extremely low threshold nowadays to throw a TE probe down and use that to calculate a cardiac output. Get a VTI, get your LVOT, some very straightforward calculations. Once you've got your cardiac output, you can solve for the DO2. And if you really want to prove this to yourself, you can sample the circuit, interrogate it, basically get, your mixed venous gas, and you can prove to yourself that you're keeping up with the patient. So this is just an important point, because our nurse practitioners, even sometimes they'll call us in the middle of the night and freak out because the SaO2 is 80%, but their lactate's normal. It's not probably great for them to be at a lower SaO2 for that long, but it's compatible with life. And that's what we try to emphasize is don't shoot for the stars necessarily. You're okay with an SaO2. And that's right out of the Red Book. They emphasize this in the ECMO Bible, so to speak. Some other things just to show you here that I really like this paper. And at the very end of this lecture, there's a QR code, and I'm happy to give, Justin, I'm happy to give you a Dropbox link with all my ECMO articles, including this talk, if you'd like that. But this is a really important paper that I think really explains ECMO. And the reason it does is because it really shows how what's going on here. If you understand this diagram, you understand 85% of what's going on with ECMO. I mean, Dan did a really good job with this diagram. We have a blender. We bring the blood from the patient via some outflow or drainage cannula. Most commonly, that's a femoral cannula, most commonly. You may have a bifemoral cannulation, no problem. But either way, identifying that blood that's coming to the pump, it goes into the oxygenator. We wind up having our exchange. And this is the magic of ECMO, is really all about the technology advances in the oxygenators over the years. And so what you get is the exchange of CO2 for O2. Your sweep gas flow is coming off the blender, sweeping that CO2 away and allowing oxygen to come across the membrane back to the patient. Most commonly, our most common configuration is usually an outflow cannula, 25 French in the groin, and a 23 French inflow cannula in the right IJ. Again, you can do this in the femoral. Most of our military cannulations are actually bifemoral. That works as well. So either way. But this diagram, and I think this paper, really does a good job of describing the physiology of ECMO. One of the things that people ask when they first start doing this is, what are the knobs that I have to worry about? Or what knobs do I even have to worry about? And what I usually say is, you shouldn't even have to worry about the knobs. The knobs are not really your responsibility. You should have an ECMO specialist or a perfusionist that's helping you. That's how we in our program, we actually train respiratory therapists to do ECMO for us so that we can save costs with perfusionists. But the bottom line is, you're not going to be necessarily playing with the knobs. You may ask for adjustments. So the thing with oxygenation is, this is the blood flow. It really is the big thing that you can influence for that. But we don't necessarily make a lot of changes with that. Again, we will be limited on how much blood flow we can get by the diameter of the cannulas. But the sweep gas flow, on the other hand, is really important, because that tells you how much the lungs are actually working. If your sweep gas flow is down to like 2 liters, great. Those lungs are probably getting better. They're doing a lot of the work. If you're at 14 liters or higher, they're pretty dependent on ECMO. And that's a patient who's pretty sick. And that's something you need to know as an anesthesiologist, because if they do get disconnected or if there's a flow drop, they're going to desaturate very quickly, versus having a little bit of wiggle room, so to speak, on the ventilator can help. So the sweep gas flow is really important. And that's what this diagram shows. Okay. So sorry about that. Let me just get out of this. There we go. Okay, so adequacy of oxygenation, I think I explained that already. Just understanding that this is all about the mixing of oxygenated ECMO blood with the deoxygenated native venous blood. And you can keep up with the patient. We'll talk about the hemoglobin goals in just a second. We do not drive our hemoglobin goals really high. We will initially, I mean, I know at Michigan, some of my colleagues there will sometimes go for a higher hemoglobin goal, but we found that, and I think we're going to see that with the ProtectMO study that was just completed. I don't know if you folks were enrolling in that, but we enrolled a bunch of patients in that, really looking at the effect of transfusion on oxygenation. And we didn't really, at least in our data, we weren't seeing a huge jump in that. So it really is about the cardiac output. That's probably the biggest determinant, something to think about. Once again, hypoxemia occurs, but it's often adequate. If you're unsure, calculate a cardiac output. Get your echo probe on, and if needed, do a TE, and you can figure out a DO2 very quickly. Okay. Then ventilation this is the second knob. So this is the second knob people will talk about. The first one is the blood flow, which often can influence the oxygenation. The second one is really the sweep gas flow. And so we do aim, in this case, unlike oxygenation, we'll accept some lower values depending on their pathophysiologic state. We will want a normal range. In fact, if they've got some evidence of right heart failure, we'll drive this down to less than 40 on our PaCO2. So this is one that we do want to titrate the sweep gas flow for. And again, the anesthetic consideration is when they come to your OR, if they're coming back, or when you initially put them on, you want to know how much support they're requiring, because it gives you an indication of how well their lungs are actually working, how much function's left. Here's just some common configurations. So we don't do the Avalon. We really haven't done the Avalon hardly at all for our trauma patients. And I don't know, we can talk, I'd be curious to hear your experience if you folks use this. And it's not hard to place, because a lot of us are doing TE, so we can help get it placed. We have fluoro widely available, but I will say that it's just not necessary. It's much quicker for us to do a fem jugular configuration. We get two teams at the head and at the groin, get them cannulated pretty quickly, or bifemoral, which we can do very quickly. And in trauma patients, that's really a good idea. We're going to talk about some TBI patients. That's one of the concerns with the Avalon is, can it cause, or can it precipitate or exacerbate congestion, because you're now putting one honking big line in one of your IJs. I'm not sure about that. I do know that there are some data on stroke risk with Avalons, and they're very expensive, by the way. So we just take a simple approach and either do a fem jugular or fem configuration. That's our most common approach. Be interested to hear what your thoughts here at the end, what you folks do. VA ECMO, wasn't sure it was going to be on the line. And I know several of you work in CT ICUs and you know this stuff cold. I do make a mention of it though, because this is where things are a lot different. VA ECMO is a whole different animal. Most of what I'm going to talk about tonight is VV ECMO. And the reason we don't use it VA a lot in trauma patients is because it's really about supporting the heart, as you know. And you get this mixing cloud, which you can track, and there's different physiologic ways we can see that. But, if their heart's not working really good, that mixing cloud is going to be right up high in their aorta. And you're going to be very dependent on the VA ECMO, the retrograde blood flow, to maintain blood flow to all the vital organs, including the brain. And so VA is not that commonly used. We have used it. It's usually restricted to penetrating injuries of the heart, maybe a really stunned myocardium. We've had one really bad cardiac contusion where we put a patient on, but we have not had great results with VA ECMO, admittedly. We'll talk about that. Most of what we're talking about here is VV ECMO. The technology for this is not cheap. These numbers have gotten a little better. We have both at our institution. You know, the Cardio Help is very portable. We use it in the military. We've got one unit that we were able to procure during COVID, but it's pretty pricey. We will use it, but it's just expensive. The Rotaflow is the majority of what we use just because it's cheaper, and that's what we're pretty experienced with. But, you know, we have several different circuits, and we use them all. We train our fellows on them all, so they're familiar with them. Really agnostic to the you know, technology in terms of really it's about the price. If you're going to have a large value program, you got to look at this really carefully because these things just multiply, and especially in trauma patients where we don't anticoagulate them in a lot of cases, you may wind up doing circuit changes. And as you can see here, and again, these numbers are just rounded up. These numbers do vary. If you make a deal with the company and buy a certain amount of circuits, they'll decrease the price, etc. But, you know, in general, you can see there's a big price discrepancy between using a Cardio Help circuit versus a Rotaflow. So again, really interested in what you folks are doing, but this is what we do. We are about 95% Rotaflows is what we use. Okay, so what's the data on this? I'm not going to bore you with the data for too long. I'm going to just go through some of this, though. I think this is one of the best papers out there. Lena Napolitano, again, Dan Brody from Columbia, Napolitano from Michigan. These are just giants in the ECMO field. I'm sure many of you don't know these folks. This was an 18-year period. I think it's one of the best, at least one of the best retrospective studies that has really looked at ECMO use in trauma. And what you see here is, you know, there's not really used that much in the 90s, and it took off once H1N1 kind of kicked in. I imagine we're going to be seeing a lot more of this with COVID because most institutions have definitely stepped up their game with their ECMO programs because of COVID-19. But we'll have to see. What's reported here is a survival that's usually about, you know, a little over 60%, which is not bad. These are sick patients. And it does depend on the indications. They talk about this in the paper. I'd recommend reading this if you want to learn more about it. But this is actually a really good, I think a really good paper that looked at this. Some other things that they looked at here again, there's their overall survival unadjusted, but survival to discharge actually was quite high. Now, 80% of their patients in this paper had a complication, but, you know, they actually had really good survival. 74% of their patients survived decannulation. In other words, they came off ECMO, and this is the final number. These are the final numbers here. And what's important here is some of the ARDS, you know, the total cohort fell a little bit because they included, I think, a couple of VA patients, but overall, this isn't bad. These numbers aren't too bad. I mean, we're talking patients that have very high mortality if we don't do anything. And I think this paper really helped a lot of us understand that this is something we should be considering, maybe a little bit more, perhaps. Again, very resource intensive, but 63% survival with a patient who would otherwise probably have died when I was doing my fellowship, hands down, you know, I'll take that. So not bad, but let me show you some more numbers. Here's just a graph I made. And I just went up to 2018 because that's where the majority of the papers were. There's been an explosion this year. Several papers, which I'll show you in a minute, but this is kind of where we are at. And the papers, all the more recent 2021 papers, are right on target with this. The point with this slide is, and the dots just represent the size of the study. These are all retrospective studies for trauma that included trauma patients. And what you see here is just the relative size of the study and kind of where the survival's at. And for ARDS, for trauma-related ARDS, the survival is actually quite high. And probably the reason for that is we're probably talking about a lot of trolley cases, which, as you know, and I know, that can get better pretty quickly in a lot of cases. So that's probably what we're looking at in a lot of these. But for all other indications, it kind of falls right around that paper that I just showed you by Swole, Napolitano, and Brody, right around 60% on average. Here's a couple of other, here's our experience, at least our initial experience. So we published on the first 18 patients that we did over 2 years. And this was, the majority of these patients were ARDS patients with post-trauma. and a few were aspiration. We've actually had really good survival with aspiration, well over 85%. Again, these patients back in the day, they would die. They just would die. I mean, 50% mortality right off the bat. So that's a really good indication to think about if you've got a trauma patient who aspirated. I know a lot of our patients are aspirating right as they get to us if they don't have an advanced airway. So that's something we're always dealing with. Bacterial pneumonia was another big cause, but the majority of this was ARDS post-trauma. And you could see their injury severity scores, 27. Their lactate was not insignificant, 7.3, and pretty good survival to discharge. And that's right where our numbers have tended to kind of stay. They're actually a little bit better than that, closer to 80%. So trauma patients actually are outperforming a lot of our other regular ECMO candidates for different indications. So that's encouraging, at least at our institution. We've enrolled well over double this since this paper was published in 2018. This wasn't in a great journal, folks. This was in World Journal of Surgery, but got it out there, and basically a case series. That's what a lot of these studies are. Here's a more recent paper. In fact, there's two papers that just came out this year. Both used the TQIT, the Trauma Quality Improvement Program database, looking at data from 2013 to 2016. So that's important because it's up to 2016. We've figured some things out with ECMO to do this a little bit better since then. But nevertheless, in this paper, they looked at propensity matched analysis, and their ECMO patients, not bad, kind of in line with what I just shared with you, in terms of survival. But and they compared it to patients who did not require ECMO. But there's some fishy things with the methodology in this paper. It's a good paper. I'm glad it's out there. It's provocative, but the reason I have a couple issues with it are because the next paper I'm showing you was by another group, and these folks found a higher survival than the other paper, but they didn't enroll as many patients. So and they also did a propensity score analysis. They had a little bit of a different selection criteria though, so their N was reduced compared to the other study. But it's just interesting. Both study groups used the same database, same time period, similar methodology, but not exact, yet they found some discordant survival numbers. 76% survival, a lot higher than this study than the other one, but they had a lower N. So take this with a grain of salt. I think, we're probably due for another good, solid, systematic review in another year or two. I'd love to see that be at a higher level of methodology where we can really look at this and try to do some sensitivity analyses to really look at the individual indications for why trauma patients required ECMO. Because with all these studies, a lot of this stuff is lumped together, and that's the problem. But I think what I'm sharing with you here is that you're going to see over and over again, the survival is better than a coin toss. It's better than 50%, probably closer to above 60, probably approaching 70 in a lot of series. And that's with the more other recent case series out of Germany. There's some other ones here that I list just to, completion. These are all stuff that I found in the lip search getting ready for this. So I think what I would conclude is, I don't think we should have a nihilistic view with ECMO. The survival is pretty good for patients that we otherwise really aren't going to have a lot more to offer other than trying to really crank up the vent and jack up the vent and hurt the patients more. If we can get them on ECMO and we've got the resources to manage them, and you have an appropriately selected patient, and preferably early. That's the other thing. None of these studies control for timing. We really believe earlier is better. We will really, we've put a good number of patients on right in the operating room. We're definitely, that's really our choice to do this, is right when they start to get in trouble on the table, we will get them on ECMO immediately, rather than try to hold, put them on APRV and tough it out. We really will try to get them on quickly so we can, and plus it's easier for our trauma surgeons and everyone because we're in the room managing the coagulopathy and doing the resuscitation with a one-on-one approach before they get to the ICU. So stuff to think about, but I think that's the literature on this stuff. It's not, there's a lot of literature. It's not the highest quality, but there's a lot of stuff out there. Okay, how do we select patients for ECMO? All right, well, here's our inclusion and exclusion criteria, and it's pretty broad. And I don't think this list is going to probably impress many of you in terms of its specificity. I will tell you that on the exclusion end, we have violated every single one of these exclusions multiple times. Even Jehovah's Witnesses, I've had two. I don't like that. I think you're really handicapped in a trauma patient who's a Jehovah's Witness, but you got to be super sure that they are done bleeding, because if you're not, then it's just going to be a terminal event, basically, and really a waste of resources, quite frankly. And there's no judgment there about the belief. It's just a fact. If you can't give them blood products and they're still bleeding, there's nothing magical about ECMO that's going to fix that necessarily. In fact, your coagulopathy is going to get worse, and a lot of times if you keep them on too long. So we violated all these, nevertheless, with the exception of uncontrolled hemorrhage. That is one for trauma patients that you just can't get around, because it will always end the same way. Severe traumatic brain injury, I'll show you a couple cases. We've had some good results with that. They have to be selected carefully, and you've got to be very clear about the risks with the family. But, if you can't oxygenate a TBI patient, and you're not meeting your goals, then sometimes this is the only option. So we've actually put a fair number of TBI patients, and I'll share our data on that, which was just published. But this is our inclusion criteria. We used to put regularly, so in that case series that I showed you from shock trauma, a good portion of those early ECMO patients were all post-traumatic pneumonectomy patients. We have since backed off on that. We don't automatically put cannulas in. What we do typically do is put a micropuncture in so that we can rapidly upsize that if needed. But that's kind of our approach. Or we'll have them on a watch where we know we have the resources to cannulate them. The cart's outside the room. But it's not an automatic like it used to be. And I don't know, I think that's probably just a testament to our surgeons, doing a lot of these. We have really good thoracic folks that can do good work with this, but nevertheless, it's not a hard and fast absolute, but one of the things we look at. I will tell you, age 65 is a hard stop for me. We have had, I think now, 2 survivors that are over 65. Both were in incredible shape. One was like a marathon runner. He did not look 65, but there is something about that. We've published on it. Above 65, there's just not a lot of reserve. And unfortunately, that for us, we just have not had good success with that. So that will be something we will be pretty hard and fast on based on our own data and our own experience. I hope we can get better and push the limit a little bit. But for now, that is just, and for COVID, we've lowered it to 55 actually at our institution. Again, anxious to hear about your experiences there, but for trauma patients, this is what we look at. And importantly, they've got to have a reversible form of ARDS. You really have to be pretty sure about that. We don't put people on if they've been on the ventilator over 10 days. A lot of institutions will cut that off at 7 days. We've pushed it up to 10 and actually have that as our published, indication or inclusion criteria. And then VA is just there. It's rare, very rare use of VA. We have not had a lot of success with VA. It really has to be a direct cardiac injury, and that's done in conclusion with very close consultation with our CT surgeons. And I just can't give you a lot of information on that because it's not something we do anymore very often. With the exception of EPR, which is a whole separate talk, but I think you've already had a talk in this lecture series about that. So talk about that at the end if you want. Here's how we manage our patients. Very simple. And I'm not sure this is the right way to manage them. I'm pretty sure it's probably not, but this is what we've done. We usually put them on pressure control, 20, PEEP of 10, and a rate of 10. If we're proning them, and we do try to prone all the patients that go on ECMO, we'll get proned if we can. Some we can't if they're spinal cord injuries or something going on with their ICP that we just can't get them prone. But most of the time we will prone them. That's our standard. We will then sometimes increase those settings slightly to 25 with a PEEP of 15, rate of 10. That's for us lung rest. That results in usually a tidal volume of 2 to 4, sometimes far less than that mils per kg. Sometimes we have a lot of patients that go down to like barely detectable tidal volumes on ECMO, only almost fully supported on ECMO. That's true lung rest. We do try to add this vent support in, and I also list APRV here because we are fans of that where we work. We use a lot of that as well. We will just calibrate the APRV with a P high right along those lines of 20 to 25 with the idea of preventing, barotrauma, volume trauma, and allow that lung to recover. So that's our ventilator approach. Very simple. Our hemoglobin management is also very simple. We'll start off at 8 and we'll drop that to 7 once they stabilize and they're meeting the goals, which I talked to you about, an SaO2 of greater than 80% consistently. We'll drop the hemoglobin to 7 and not transfuse anything above that. How do we land at a platelets of 40,000? Certainly if they're bleeding, that's all bets are off. By the way, whole nother talk, but we use a lot of thromboelastography with our ECMO patients. We used to get a tag almost every day. We stopped doing that. We now get them on demand. And we also have Rotem in our shop. So one of my colleagues and I will go downstairs and run Rotems on these patients, but you have to do it in the operating room. So we have to make a little field trip to do that. But either way, again, I'm agnostic to both of them. I think they both work really good in this patient population, but we do use a lot of viscoelastic monitoring. But barring any bleeding, we just leave the platelets around 40 and we try not to transfuse. That kind of arose from more of a conversation with our blood bank and some very loose data that's not really based on any kind of major prospective studies. Our heparin infusion we have studied. And so if we do get a patient on heparin, we will put them on a low heparin infusion, 45 to 55. So we don't go above that. COVID patients, whole other ball game, but trauma patients, most of our trauma patients, we actually do not anticoagulate other than an initial bolus to put them on ECMO. After that, we'll often give them 24 hours without any heparin just to let them settle out. But that is our standard. If they're able to tolerate anticoagulation, we'll challenge them. We don't bolus, we just start the infusion and we aim for 45 to 55. I got to tell you, I'm not sure if that's the right answer. I know other institutions, again, be curious about what you folks are doing. That's what this whole thing's about tonight. I'm not sure if, our Gatraban or Bival are better options. I know a lot of my colleagues at other institutions have really done away with heparin and they feel like they get much better results with Bival and our Gatraban. But for now, we stick with heparin. We have a very, very low incidence of HIT and we've gotten away with it. And again, a lot of our trauma patients don't get any heparin, hopefully if it's a short run anyway. Here's a patient that we had protocolized management, proning. So we will prone patients for 8 hours the first day, and then 16 hours a day until we don't feel like there's any more benefit. And what do we mean by that? That means, maybe their x-ray is getting a little better. Maybe they're starting to develop some early signs of some skin breakdown, but whatever it may be, it's really a judgment. But our standard is to do at least usually a good 4 or 5 sessions of proning, even if they've got other injuries. We try to get them proned as much as we can. And again, we aim for a PaCO2 in these ranges, as I've shown you. When we get them off, we recirculate, meaning we just shut the sweep gas flow down completely. And we used to have rapid recircs and decannulations. Nowadays, we're a little more conservative. And I don't know if this is the right answer. I know colleagues at other institutions will do much shorter recirculation trials before they get a patient off ECMO. We usually wait a whole day on recirc before we will pull the cannulas, just because we want to be absolutely sure. We've had 3 recannulations that I'm aware of. It might be 4. I could be wrong on that. I think it's 4 recannulations in the history of our VV ECMO program. And all but 1 survived. And the 1 patient who didn't was a trauma patient who had just an overwhelming infection. He actually had mucor. So there wasn't much ECMO was going to do to fix that. But we try to avoid it. It's not good form to have to recannulate. So it's rare, but it can happen. And that's why we like a nice conservative recirculation trial. So sure you folks do this as well. We walk patients as aggressively and as frequently as we can. As soon as they're ready to do it, we get them on their feet. We have a team. It's safe. We have never had a cannula get dislodged. We've had some hypotension and some incident. We can lay the patient back and get them back to their room. But we really believe this is a really important part of our ECMO program, is getting patients mobilized. And it can be done with the FEM jug configuration. We've walked patients with the bifemoral cannulation and been successful. You have to watch it, and we're really careful. This guy was just about ready to come off ECMO. As you can see, he's looking pretty good. but that's a really important part if you get to it. Some of the patients aren't going to be able to do this, but that is always our goal, is to get them up and walking. Some of the things we deal with post cannulation, a lot of these patients have DVTs. The majority of them do, in fact. And so we will at 24 hours check them for DVTs. And we've published on this, 85% of these patients are going to have cannula associated DVTs. We have a very simple way of managing that. We'll bump up their anticoagulation at this point up to 60 to 80, repeat it at 2 weeks. And, unless a lot of them are not positive at 2 weeks, over 50%, over 60% are gone by then. And so it's fairly rare that we have to put a patient on 3 months of anticoagulation. But if we have to, we'll do it. And then we also try to get them at that point on a DOAC or a NOAC, just because it depends on their insurance, but it's just much easier to manage. But very common to see this, and this just requires a lot of surveillance. Okay, so that's the majority of how we do it at Shock Trauma. I try to distill that down to some just real basic stuff, review the literature, demonstrate what the reported survival is out there. And let me just share a couple cases with you, things we can talk about at the end here if you'd like. So here's one case that we had right before, about 2 years ago. 18-year-old male, dirt bike crash. This is not his picture, I just pulled that, but it was very similar, riding fast, riding hard. He actually did not have a helmet on. So he was intubated in the field. His GCS was 3T, non-reactive pupils, really banged up, bad leg fracture. You can see here when he got to us, he was actually fairly stable hemodynamically, but definitely had a bad TBI. Here's his X-ray on admission. CT scan, not horrible. Problem was, though, he wasn't really waking up. His GCS at best was about a 6T, and starts to really have some problems with oxygenation. Now, he had an EVD in. He had an external ventricular device placed, and his ICP was stable. So that was an important data point in looking at this guy for ECMO. And by day 7, he started developing increased ventilator requirements, and we proned him. And he developed barotrauma and got another chest tube and paralyzed, all the good stuff, and just wasn't getting better. And ultimately had a MRSA pneumonia, bad MRSA pneumonia, which, as you know, has a very high mortality. Oh, and by the way, we had gotten now an MRI, which showed that he had a grade 3 DAI. So, and this is his X-ray. Can start to see some of the cavitary lesions forming, just bad bilateral infiltrates. His admission one is at the upper left for your review. This is just very typical. This isn't even that bad of a chest X-ray for most of the patients we do ECMO on. But so, these are the questions. Do you offer the family ECMO? This is a young guy. He's 18 years old, but he really hasn't gotten a lot better. Is it just early in his course? It's only day 7. And we know MRSA pneumonia is pretty bad. We got him on the right antibiotics and stuff. It is a reversible cause, however. So we put this guy on. I'll just tell you, we put him on. I wouldn't be presenting if we didn't. But, how would you cannulate a guy like this? TBI, he still has an EVD in. So, we bifemoral. And as long as these are placed appropriately, you're good to go. We did start him on heparin 5 days after he was on ECMO, and we just were really careful. We sent him down for serial head CTs about once a day once every 12 hours for the first, after the initial cannulation, then once a day for, I think, 2 days. And then actually, as he started to oxygenate better and he got better from his pneumonia, he woke up. We walked him. He was on ECMO for quite a while, 41 days, but, he woke up and was discharged from the hospital 2 months later with minimal neurologic deficits. I say minimal because he was 18 years old and he was ready at that point in follow-up. We have a follow-up ECMO clinic, by the way, which we try to follow all of our patients if we can. So we're accumulating data on that, which I think will be very interesting in the next year or so. Hopefully we'll get that published. But this is one of the dramatic cases where he went to a trade school. So good outcome. And this is also our experience here. This is just some of the more this is, since we've been doing this, we have not put a lot of, to be clear, we have not put a lot of TBI patients on ECMO. This is a 10-year experience at Shock Trauma, and we've only put 13 patients on. And this is kind of our results. You know, it's not great. I mean, this definitely will take a hit in your mortality, but you might get some cases like I just showed you with people that are able to walk out of the hospital, you know, if you're careful. So these are some of the complications you see there. It's very common to see circuit thrombosis. We watch these circuits like a hawk because, like I said, we don't usually put them on any anticoagulation right away. And the survival when you have a TBI definitely takes a hit, as you see, 38%. With a couple of those dramatic cases like this kid, they keep us going. So it's not crazy to do this, but I think you just have to have a really good conversation. In this case, we had a really good relationship with his mother. She was well aware of the risks with this. And, you know, we just reminded her about that almost every day and made sure our communication was very clear with her about this. Here's another one that we, you know, kind of a common way that we'll get to ECMO. 26-year-old, he bounced off the guardrail, deep laceration to his neck. They diverted him to a local hospital, which fortunately was very close. And they somehow got a trach through his neck wound into his airway. Don't ask me how he oxygenated en route to the hospital, but he did. And he was able to get there with SAT that wasn't exactly measuring. It wasn't measuring much better by the time he was transferred to us at Shock Trauma, but he was emergently transferred to us. He was hypotensive on arrival and not oxygenating great. He was really agitated as well, difficult to sedate, huge wound in his neck, and had an obvious surgical airway, a trach tube in his neck, and a large laceration as well to his chest and all through his perineal region. I mean, he really bounced off this guardrail, severely injured. In fact, here's all of his other injuries with an ISS of 66, which, as you know, is ridiculous. I mean, 75 is tops, which is almost not compatible with life. And 66 is really pegging your ISS to a really high level. So these are all the injuries he had. Importantly, the tracheal separation. Importantly, the beginnings of some lung contusions and also a splenic laceration with pseudoaneurysms, and also had some end plate fractures in his thoracic spine, and we didn't have a good neuro exam on him. So, you know, what do you do in this case? Here's his CT scan. Not horrible. You can see a bit, got a pneumo there, which was treated with a chest tube, beginnings of a pretty good lung contusion, right greater than left. So he went to the OR. He got a splenectomy, which is good. So that was taken care of. Got a colostomy for some other injuries as listed up there, GJ tube. His neck was explored. They fixed his trachea with a primary repair and EGD to make sure his esophagus is okay. And so here's some pictures of the OR, you know, kind of a fun case for us because we were involved with getting him reintubated. It was just kind of a reversal of, you know, putting an airway exchanger. As you can see, the Cook catheter went back up, just a kind of a cool airway case, but wound up having a really good tracheal repair. Problem was, he was not oxygenating great at that point, and the surgeon was concerned about that tracheal repair and really wanted to make sure that that repair was going to be robust. And so to play it safe, well, play it safe, it's risky to put a guy like this on ECMO, but that's what we did. We put him on ECMO, and, you know, he wound up not getting any heparin because he did have a TBI. It wasn't as bad as the one I just showed you. He was only on ECMO for 6 days, and actually he made it out of the hospital, walked out of the hospital, neurologically intact as best we could tell, and his trach was removed right before he was discharged to rehab. So another really dramatic case of where ECMO can be used to bridge you through some difficult problems. One last case, this is really recent. So this is literally the guy I was telling you that I had in my ICU now, coming off duty earlier this morning, over the weekend, last week. 19-year-old male, high-speed MVC, pretty good subdural hematoma, right lung contusion, really bad arterial injury, pelvic fracture, bad femur fracture. And I emphasize that. And a bad fib fracture, also emphasized. He also had a transtibial amputation. So this is a really bad MVC. And he was ejected. from the vehicle. So you can assume that the mechanism was really congruent with this type of injury pattern. So, not doing great. Initially. Very shortly after he was in the OR, got his fractures fixed in a staged approach. By hospital day 3, here's his x-ray, and he is not statting well. He's got PaO2s in the 50s, and we proned him, and that was actually great. His PaO2 jumped up to 200. So we were thinking, okay, great. We're going to get out of this with just some good proning. We don't know what's causing this. He got a massive transfusion, but this was not something that, it didn't seem like a trolley because it was a little bit delayed, and it seemed like it was getting worse, not better. Although he did respond to proning, until he didn't respond to proning, and his oxygenation got worse even with proning. So this guy eventually was really not doing well, and the decision was made to get him on ECMO. Here's a CT. You can see a lot of posterior disease, which probably explained why the proning was, probably efficacious, at least initially. So he got cannulated in our standard configuration. He had a pretty short run of only 15 days. And I'm really happy to say he's on a trach collar now, and he's neurologically intact. He's an 11T because he's trached, but he's interacting with us and telling us what he does and doesn't like. And his x-ray now is looking really good. And what was this case then? What the heck was this? So here's what we think it was. We think this case was probably a case of fat embolism syndrome. And we do see a fair amount of this. I feel like lately I've just been seeing more of the cerebral manifestations of this. But in this case, here was the key with him. He did have a persistently altered mental status, but it was hard to see if he had any precordial petechiae. But when we looked in his eyes, there was some subconjunctival petechiae, and his ARDS was not getting better. And so that was where, we kind of called this basically fat embolism syndrome, for lack of any better pathophysiologic explanation. He never aspirated. His x-ray, which I did not show you on arrival, was really pristine. But, another case where you can use this for stuff like this, to get yourself out of trouble. It's risky, again, TBI, but he had a short run. We were able to get him over the hump. And this has been described as well. Here's another small case series from Japan, where they talked about managing patients on ECMO for this exact same problem. And here's their case series. You can see that they had the majority of their patients, all but one, actually lived. The one patient who died, it looks like, this was a lung transplantation case that they were talking about actually post-op. So really not as relevant to the femoral. All these are long bone fractures and stuff. So, think about this with your long bone fractures. I'm sure you guys see this a lot at your trauma centers. We do as well. It's something to think about. So that's it. I just wanted to share, again, an overview, talked about some of the literature, and then shared a couple cases with you. And if any of you want to access to any of my papers or whatnot, I put most of them in this Dropbox file. You can scan that QR code. I know Justin is taping this, and I would be delighted to hear what your thoughts and experiences are at your institution.
Well, Sam, thank you very, very much for that. That was wonderful. And you're right. It's really nice to hear what other people do, because we see what we do, and it doesn't come up that much. It is something that we don't thankfully have to do every week or even every month. And so it's always kind of a big deal, and it's really nice to hear that other people are going through the same pains and situations that we are, and even the same cases. I mean, that last case sounds stereotypical almost of what, when I look back at ones that we put on ECMO, that's what it is.
Yeah.
And I don't know. Is it fat emboli? Is it the massive transfusion? Is it trolley? I mean, I've been leaning more towards just taco. We just overload them and that's what it is. And it's almost part of the deal to get them through. We try to be, I know I try and be a little bit aggressive on it, going as soon as when we think about it, it's the time to call.
Yeah.
My first question is, who actually puts your people on ECMO?
Oh boy, you couldn't have asked a more timely question. So the majority of my week is going to be a series of high level, hopefully final discussions about who is going to be doing this going forward. So to answer your question, in the trauma center, it's very straightforward. We have a great relationship with our cardiothoracic surgeons. They have historically managed most of the cannulations. They've had their residents do them, or their fellows, and with one attending. So a two-person team strictly from cardiothoracic surgery. In the last 6 years, though, we've had an influx of some really high-level vascular surgeons who do trauma. Rishi Kundi, Johnny Morrison, and you guys have read a lot of their papers, I'm sure. And Johnny's very well known in this field. Joe DeBow is another great guy. So they're able to do it, and we have all of our surgeons are qualified. But if we're going to keep doing this and going forward, I'm a real big pre-hospital guy. That's really my thing. Is how do we get out of here and get on a helicopter and bring our stuff to an outside hospital, get them stabilized, rather than try to limp them in on ridiculous APRV settings or something. So that has now led to a discussion where they're going to open the door for intensivists to do this. I would argue to you, Justin, I would argue to everyone in this call, for the non-surgeons, so I have cannulated. I'm not on a cannulation call, but if there's a cannulation going on, I'm happy to jump in. I think that as anesthesiologists, intensivists, we put a ton of lines in. It's not just a bigger line. There's a lot of considerations to it, but I think when you do this with a smart approach, I'm a big fan of TE. If you don't have fluoro, throw a TE probe in. And the short answer to your question is we're going to be opening that up more to our intensivists. I don't think our anesthesiologists that are not trained in intensive care will be doing this, but it's not to say that they, right now even, we'll get lines in preparation for this that can be upsized. But the short answer is it's been an evolution. I think hopefully this week we're going to have our final credentialing process so that intensivists, anesthesiologists can do this. And I know that other places, that's their model. So what about you guys? Who does it at your institution?
I mean, it's CT surgery only.
Okay.
And it's, and I have friends at other places that, are intensivists as anesthesiologists, and they'll cannulate their own patients.
Yeah.
They may be at smaller hospitals where they may not have a CT surgeon in-house all the time.
Yeah.
We have fellows in-house all the time, and the attendings are pretty quick to get there, and they're normally very responsive when we call in the OR and say we have an issue.
Yeah.
So I'm not saying there's a problem that we've had with it, but it is one of those questions of we're already in the OR. We already kind of know what we want to happen.
Yeah.
Do we need to call anyone else, or should we just be able to do it ourselves almost? It just a natural transition.
Yep. Yeah. No, I think it's within the realm. I mean, I think also when you start to talk about some of the crazier stuff, which we didn't talk in this talk, like eCPR, and talk about doing this in the pre-hospital. And you and I both know there's a lot of anesthetists and intensivists that are doing this actually. So it's not an unprecedented concept, but you're good with lines, you're good with ultrasound. I think you have to, keep your skills up. Like our process with which they're proposing, totally non-evidence based, 5 cannulations with direct supervision, hands-on supervision, and then at least 5 a year is what we settled on. I don't know if that's enough. The thing is, in our place, if we get into trouble, there's always going to be someone there. You're swimming in the deep end with a lot of your friends. It's not like we're going to be in a community hospital, but we are talking about we lose a few patients every year that we cannot get to shock trauma because they're too sick to transport. And we do believe we need to be going out into the field and doing a few of these a year. And so that's the program we're trying to set up now.
Well, and I think the other part of this where we probably run into the bigger issue is where are they going to go afterwards? Because ours are exclusively cared for in the CTICU.
Yeah.
Even having 2 CTICUs, bed space is beyond a premium. And having an own ECMO unit does help that, I think, a little bit, because you at least have a place to hopefully put in the place to put them for overflow too. And we always are able to make a bed. Again, it's one of these things, we're able to do it, but you just wonder if there's going to be a simpler process at some point.
Yeah, you're right, Justin. I mean, and that's an advantage we have. Our CTICU is actually our overflow spill unit, and they do a great job, but we have a dedicated ECMO unit, and we actually have another unit called a CCRU, critical care resuscitation unit, both 6 beds where we can land a patient like at a moment's notice outside of a pandemic.
Yeah.
But yeah, so we're lucky that we have that. But you're right, you got to have, that's part of the program, having a place to land them without burning your CT volume as well, which is equally important, you know.
I know, again, comparing it to, kind of what we do here, and I know there are a number of intensivists and people that rotate, or, either as a fellow or as an attending, rotate through the CTI. You brought up what else is different? And, I focused especially on the ventilator settings. That was a big thing. I think COVID made us re-examine what we do for these types of patients. And it's one of my pet peeves, or kind of one of my areas that I've always looked at, that we did not really have a great way of managing these patients. And if we did, it's like, is it really applicable in COVID, or do we need to look outside the box and, APRV, things like that? And again, proning them, we got more aggressive proning ECMO patients with COVID. I'm not sure, we were doing it as much as we could have beforehand.
Yeah.
And I'm hoping some of that stuff definitely sticks. The point that really stood out, and I know most of the trauma surgeons are going to agree on this, was the use of anticoagulation in TBI. I feel like this comes up a lot, and I'll let them, kind of address that. But it does feel like we fight a little bit more with our neurosurgery colleagues to get anticoagulation started.
Yeah.
I was impressed hearing 5 days on a TBI.
Yeah.
Getting it started well. And we often don't use a lot of anticoagulation necessarily with VV ECMO if we can. So
yeah, no, I'd be curious to what you say. I mean, we've had several runs where we've never used any heparin, to be clear, at all. And it just have to watch the circuit carefully. I mean, there are data on that. It's all retrospective, a lot of case series, but I also know other colleagues that have taken an approach to all their ECMO patients, notwithstanding COVID, of course. That's always the outlier. I think that's a whole separate, pathophys that we have become intimately familiar with. But I mean, I think that's the part that we don't get stressed about as much. As if we have to just not be on it, we're okay with it. But I don't know. Also very quick to get a CT scan in our shop. So, our nurses are really adept at, kicking the tires and moving the patient on ECMO down to the CT scanner for a quick scan if we need to, and it's not that far. So that's another factor that we're a little spoiled by. I'm not sure if that's as easy to do at a lot of other institutions, but I'd be curious. See, that's a battle you guys fight a lot, huh?
it sounds like it. And again, I know there's some surgeons on, they may know more about it. I definitely it seems like this comes up a lot. And it seems like even with just DVT prophylaxis, things like that, we've looked at this, and it seems like it's an issue. If any of them want to come on, they're more than happy to make a comment. Just going through the chat, I know there was also a question about sedation for these patients while on ECMO. And again, I think this has come up in COVID, and we definitely, our ECMO patients are notorious for how much sedation they require. And we've definitely gone with, they do not move, and anything we can do to keep them down. I know that's not the same at a lot of other places in the country. But what do you do, especially when you're trying to balance, patients that are going to go to rehab soon, in terms of safety, what's your approach for safety?
It's a huge challenge. I think that's one of the most challenging parts of managing these patients. And it stumped me the first couple of years I was doing this, until I sat down with one of our pharmacists, and she explained to me a couple of things about the circuit and how it, like fentanyl and different things that we would use actually get bound out by the circuit. So I think ECMO plays a role in that, quite frankly. And number one, but number two is one of the things we've done, and we have there's a paper that our folks have published on. It's not a great paper. It falls into the category of, another retrospective kind of case series, which not the highest level of evidence, but here's what it is. What we'll do a lot of times is partial paralysis with cis-atra. So we will use cisatrine. We will not titrate it to a train of 4. We'll titrate it to a respiratory rate less than like 25, 20, whatever we think. Usually 25 is what we land on. And the patients will oftentimes, still be able to move their arms. It slows them down though to prevent that. If you really believe in that atelect trauma, I got to tell you, some of our folks don't buy into that. They're fine with the patient breathing 40 times a minute. I'm not. So when you do that though, you still have the same problem with sedation. So, we will rotate through a lot of different things. We'll use a lot of ketamine, and I'm not sure if that's always the right answer. And then unfortunately, benzos sometimes wind up being the trick that we have to revert to with a lot of delirium, and we just have to get through it. Our ECMO runs at our institution, I think, are very long, and that's something I think we need to process and improve. And it may be because we haven't really figured the sedation out. I'm encouraged by a lot of these short-acting agents. I've always been a fan of Tivas in the OR and using other short-acting agents, and I've tried to do that. Our pharmacists don't like it because remifentanil is expensive, and but rotating in different opioids if we think pain's a component. I actually, the last comment I'll make about that, Justin, is I really think we should be looking at volatiles more. We should really be looking at volatiles with this population. We're supposed to be one of the sites enrolling with the Anaconda device. I don't know if you guys have used it. Maybe you have. And I think that comes with a lot of logistical challenges. But you and I both know that could solve some of these problems sometime. Maybe something that's worth how much would get absorbed. I mean, we can do it when we're on bypass. So that's another thought. But it's a challenge for sure.
Well, it sounds like we're in the same boat. That sounds very much like our approach.
Okay.
I like the idea of, like partial paralysis, just to make sure they don't run off, or, you can catch them a lot easier. That's an interesting idea. And with COVID, I mean, this all came up again, and I know places, we'd fight the sedation, and that seemed to cause all the problems. And I would talk to some other people, and they're like, just turn it all off and pull the tube. They don't need it. Like, that's okay. I don't know if I have enough experience to say that's what I'm going to do in the next one. But I think we're in the same boat on that. It sounds like we're going to fight these issues. Does anyone else? I know a good number of people are still on. Anyone else have any comments? I'm going through a chat there. There were just another question about site preferences. I know you said you don't, you do sometimes use the Avalon, but often it's peripheral cannulation, not much central cannulation.
Very rarely. Yep. Right.
Anyone else have any comments, questions, anything they want to ask? We're over our time a little bit. I guess you answered it all.
All right.
We're all good. Well, I guess one last time, thank you very much for doing this.
Thank
it's
you.
been a pleasure. Hope to see you again in the future. And looking forward to doing this again.
I'll be following your stuff closely. Keep up the great work you guys are doing. We're all following your stuff, and you're leading the way. I mean, this is the future of how we can stay connected, and you're leading the way. So thank you so much for being a tiny piece of it, and really appreciate the opportunity to do this tonight. Thank you.
Hey, Justin, thanks again for keeping inviting us.
Oh, there's my man, Justin. All right. Other Justin. All right.
I want to say thanks for including us in all this.
Absolutely. It's more than a pleasure, and we'll keep chatting, and I think we can maybe try this again if you guys want, aim for the new year sometime at the end of the academic year, if you guys want to pick another day, and we'll do it again. All right.
Sounds good. Thank you.
Thank you, guys. Next month we have someone from neurosurgery. I don't have my papers in front of me, and I don't have the topic yet. I'll send out the invites soon, but thank you very much. Have a good night.
You too. All the best.